Well, my clock has formally struck 1 p.m. We are thrilled to welcome you to our conversation with Tom Jackiewicz, the president of the University of Chicago Health System, where we will be exploring the topic of healthcare for a long life world. My name is Seth Green, and for those of you who I don't know, I'm the dean here at the Graham School at the University of Chicago, and I'm thrilled to welcome you virtually to our campus. There is snow coming, so this is more of a prediction photo than a current state because the green is out now, but it will be replaced by white, it shows later today. And for those who are not familiar with the Graham School, I will just say that we are 130 years young. We are the School of Lifelong Learning here at the university, where people come to engage the timeless liberal arts and to engage in the big questions of today. And for those who want to go deeper beyond this, we have a number of exciting opportunities for you coming up just in the next week. We have a sample class where you can peek into our classrooms and look, in this case, at George Washington's farewell address and think about how that text resonates today. You can learn about how to become a returning scholar at the university. And then we'll be previewing a little later this month a course that's coming this spring on the future of media in an age of disruption, looking at the very changing business model and how that affects journalism, trust, and the information you receive. But the reason that you are here today, let me just take down my screen, is to hear from a leader here at the university. The context behind this conversation is that I had the joy of having lunch with Tom a month or 2 months ago. And the reason was I was trying to get his ideas for some of the work that we're doing around longevity. And by the end of that conversation, I was so blown away by his insight that I asked him if he could share his genius with our broader community alongside many of the great points of advice he gave us for our programming. And so, Tom, thank you for accepting that invitation. I'm really excited for the conversation ahead. And I'll just formally introduce you. Tom Jackiewicz, as I mentioned, is president of the University of Chicago Health System. It's a $4 billion enterprise with 7 hospital clinical enterprises. It integrates the patient care mission of UChicago Medicine and the education and research mission of the University of Chicago. He previously served as CEO of Tech Medicine of USC, and before that as CEO of University of California, San Diego Health System. I am amazed that he could be around all those germs for so many years and continue to be so healthy and vibrant. And so that is among the many things maybe we'll get into over the course of this conversation. But let me start, Tom, just by laying the table here, which is you oversee a mammoth healthcare system. And I don't think people always appreciate the full size and scope. And so before we get into the expertise, I'm curious if you could share a little bit about the health system and just give us a snapshot of UChicago Medicine.
Yeah, no, happy to, Seth. And I don't think I can live up to that introduction, though. So first, when we talked about UChicago Medicine, we really have 3 parts of that. We have the health system, which I'll talk about in more detail. We have our research enterprise, and we have our educational enterprise. And it's going to be sort of what those 3 together, sort of what makes it really very special. On the health enterprise, we have 7 hospitals, including a children's hospital here at Comer Children's Hospital. And we're continuing to expand. So we've got obviously the UCM hospital, we have Comer, we have Ingalls out in Harvey, Illinois. And then we have the partnership with the Adventists, where we're 51% owners of 4 hospitals in the western suburbs. We've recently opened a facility in Northwest Indiana, and we're continuing to build. So, part of my sort of mandate is to continue to grow the health system in the upper Midwest. And I think there's a real lot of opportunities. But I just realized this is a very special place, the University of Chicago, and there's a lot of tremendous people here. So I feel very privileged to have this role.
Well, let's jump in. UChicago Medicine is a vital leader in many areas of human health, but today we're going to talk about healthcare and longevity. So I want to focus our conversation there. How are growing lifespans and health spans changing the way that you think about your role as a healthcare system in supporting your patients?
It's really an important question. And it's one of the things I think this is probably one of the most exciting times in my career, because I feel like there's a lot of change. So we know people are living longer, and I think there's a lot of challenges in that. There's a lot of conversation about cancer being a chronic disease, right? And as part of our new cancer center and developing that, which will open in 2 years, is really thinking about cancer patients not only coming for this episode of care, but really coming for a continuum of care over their whole lifetime. There's challenges. I think everyone's read about sort of more youth cancers and people are getting cancer younger. I mean, I think there's a lot of reasons for that. I could speculate. We'll have to wait for the science to come out. But I do think as we think about the human experience here in Chicago or in Illinois, about the challenges people are facing, but they're going to be our patients for life. You know,
Right.
academic medical centers were built around this idea that we're going to be the best for that episode of care, whether it's cardiac surgery or cancer. What we're beginning to build out is systems where you come in, you know, and because we have a children's hospital, a perfect situation when people that come in are born here and they really get their care through their whole life. And we actually really focus on what can make people as healthy as possible during their life.
So one idea that you're drawing on, which we talked about over lunch, is the personalization of care. And I was struck by it because, $4 billion enterprise, mammoth institution, very rigid structure in healthcare, the payer systems, all of those pieces, and yet a vision of personalizing. Talk about how you approach personalization conceptually and then how you operationalize that idea of personalization of care in a large system.
Yeah, you know, it's like I always say, the most important patient is the person I'm talking to, right? Because their care is what really matters most to them. And thinking about it from increased genetic screening and what we're doing so that we really understand what an individual patients, what their challenges are, to our expansion of primary care. Also, we're working on in flipping gently over to tech for a second about how we're going to make it easier for patients to access us for all their care so that they can get care tailored to how they want it delivered. I think it's really important. I think convenience in healthcare has been, I think, sort of kind of fallen to the bottom of the list. But part of our personalization is bringing it up to the top of the list and make sure we're delivering care where individuals want it. You know, I see that, you know, this idea of like expanding primary care and making sure it's easier for people to get that sort of tailored care. You know, I want to go into some specifics. We have a geriatrics clinic on the south side, which is for patients 65 and older. It's been in existence for quite a few years. It's had a huge impact. It's really been focused on trying to personalize care for seniors and dealing with their individual challenges. And when you look at some of the outcomes data, it's really very impressive in terms of reduced hospitalizations, better wellness. Um, and I think those are all the kind of things that are really going to matter. The other part about this too is I think things like GLP-1s and other sort of drug discoveries that are really having an impact on people. You know, we talk about the weight loss piece, but there's been a lot of data about the sort of general impact on other diseases and inflammation in your system. I see this sort of as we develop a system is it's going to be very focused on an individual's sort of current genetics, their health, their environmental factors, and really beginning to tailor care to that individual. I mean, from a data systems perspective, care delivery system, it's a complete revolution. And I haven't even talked about the microbiome and all the stuff that we're one of the leaders in that, about how that science is going to affect what drugs you take, how you eat, obviously alcohol consumption, other things, but to really sort of I think we're going to be in a position to really be able to tailor the healthcare to really improve people's health and get them better quality years as well as extra years.
Well, so I think it's so interesting because one of the things that I've just noticed as a person in healthcare systems is how much general guidance there is that doesn't necessarily fit my exact experience.
Right.
And then you realize, oh, so for me, these things work and these things don't. But a lot of that is both trial and error and then becoming more and more aware beyond just my healthcare appointments using AI or other, data points. And I'm in a very privileged position in terms of how much information I can access and how much I can personalize myself. But the idea that you could potentially look at my experience, use that microbiome and genetic data, and begin to inform me and match me to the most valuable health opportunities, I think is really compelling because I feel like I've spent a lot of my leisure life trying to figure out, what are those recommendations that actually work for me? Because in my experience, it is hit or miss. There are things that, I'm told are good and I can't quite see it. And there are other things. And then over time, I begin to realize, oh, so these are my unique features or my unique value drivers that might be different from someone else's. And not to say that overall the health guidance isn't right. It's just that some of it matters more or less to me based on my unique situation, if that resonates with what you see.
Yeah. Yeah, no, it sure does, right? And I think this is where the challenge is for health systems as we plan our future, is because every patient's going to want exactly what you said.
Yeah.
Is to take and the amount of information that's available today is mind blowing and easily accessible. I think AI is a complete game changer, and we've begun to really focus our health system on key AI initiatives that can really sort of begin to impact care and how we're going to do it and how we're going to interface with our patients. You know, our we recruited a new marketing director, Andy Chang, and he comes in with a very different perspective about creating what we're calling an omni-channel experience about getting information to patients. And if you will, being a fully, I want to use, it's coming to mind sort of like wrapping around the patient in the sense that all their needs are going to be met both from an information and a clinical basis. So they can, they can feel really good about the care that they're getting. And really, because the other part about this is the health system is a partner with the individual to really improve their care. The health system has to do their part and the individual has to do theirs, but making sure patients have all the information they're going to need in a way that's digestible, because there's, as you know, there's a lot of information out there, so that people can really sort of maximize their health. One of the things I always feel very personal about is the fact that I have access to all these great experts and I can ask all the questions, but everybody should have that kind of access. They should be able to get that kind of, if you will, access to that kind of expertise. There are some very interesting companies out there that are really working on things about care delivery models, leveraging AI as well as with doctors' expertise. I think in 2 to 3 years, we're going to see some things where I think are going to be I think people are going to be very impressed at sort of almost the instant access to care, as well as the quality of it, and really trying to make a difference. So because I think all of us want to get the care that we want very, very quickly. And if you ask me, the one thing I will say about Chicago, and I think probably most people on this call who live in Chicago, getting a doctor's appointment in Chicago is not the easiest thing in the world.
Yeah. Well, so let's talk about the inequities that you've already referenced. They are deep and very profound. I mean, if you look just at, for example, the death gap between where we sit in Hyde Park and a neighborhood over in Washington Park, we're talking about more than a decade. And so, this is a very unequal access today. I know this is a big part of your focus, leading a health system that has its center point on the South Side. Can you talk a little bit first about the disparities in healthcare today, and then how you as a healthcare system are addressing them, and even thinking about how technology could be a way to close the gap rather than potentially the real possibility that these technologies widen the gap?
Yeah, I actually, I spent a lot of time sort of thinking about the South Side challenges. And for people that don't know, there's data out there that if you look at someone in Woodlawn versus someone in Streeterville, they can have a 30-year age, on average, 30-year difference in age and lifespan. And, University of Chicago plays a really critical role in the South Side. We are the go-to place for specialty care. And you've got a problem that really was sort of set in motion 100 years ago, right? With the redlining in Chicago, the segregation, and now you're facing acute poverty on the South Side. And as a health system, I feel like we are destined to help be the key part of the solution on the South Side. And we've been working with the South Side, the FQHCs, the federally qualified health clinics, which provide a lot of primary care on the South Side, and working with specialty care, because what's happening today is when people need specialty care, they come to our emergency room and they come sicker than they should be because they didn't really have access to, let's say a cardiologist or a neurologist, things that you would almost, or rheumatologist. And so they come too late, a lot sicker, and of course their outcome's not going to be as good. I think part of us is working with these FQHCs and the safety net hospitals and building a specialty network and beginning to provide, that sort of infrastructure of care. So what you can access, let's say in Streeterville or in one of the suburbs, you should be able to get on the South Side of Chicago.
Right.
And it's not going to be easy, and it's going to take a while. But I do feel the University of Chicago, our destiny by our location. We really need to be the leader of this. I've had multiple board conversations. Our board's been very supportive of moving our front door from Hyde Park into the community. Because when people come, not that our emergency room's really very important, needs to be there when people need it, but we need to be providing more care in the community closer to people's homes.
We have a question in the chat from John Budd, Woodlawn versus Streeterville, picking up on your nearly 3-decade gap between the two in life expectancy. A lot of it, he says, which I know you know as well, is due to the social determinants of health.
Right.
What is the role of the hospital system, if any, to help address the underlying issues, which just gets into this broader question of you're trying to move health. You're not necessarily the most important ingredient based on all the data.
Right.
Even if you're a key ingredient, how do you think about the role in influencing the other ingredients on the menu, so to speak?
So yeah, so I break it down into 4 pieces, right? It's safety, number one. People have to feel safe. They can't go out, they aren't going to exercise. I mean, we have over 1,500 gunshot victims per year at our hospital through our trauma center. That is beyond unacceptable. And we have to improve safety. And that is really working with the police department, working with the communities to really improve safety. Health, I have second, because we have to improve access to healthcare and we have to improve the overall care people are getting on the South Side. There's got to be investment in the community. And I think we're seeing some of that, but I think continued investment. And the last one is training. We've got to create job training opportunities. We're very focused on hiring out of the South Side. About 25% of our new employees come from the South Side because actually people need to have an economic path to be able to turn their lives around. But we need more of that and we need more focus. I mean, the University of Chicago, I think, is doing a really good job of trying to really hire from the South Side, hire from our community. But we're just one organization. I think it needs to be bigger. But Seth, I always go back to the fact, South Side of Chicago is a 20-minute train ride from a tremendous downtown in the third largest city in America. This has got to be a solvable problem, right? If everybody kind of comes together, we can focus on this and sort of tackle this acute poverty because it's right here. It's right here in our backyard. And I think one of the things that I feel like being at the University of Chicago and one of the great parts of my job is I can help focus on this and try to really make a difference in the community. There's 400,000 to 500,000 people on the South Side of Chicago. That's our future workforce. We talk about shortages in healthcare and not having enough workers. Well, I feel like I've got 400,000 to 500,000 people that have been sort of, if you will, underappreciated and we can really create economic opportunities for them.
When I know we're working with community colleges on just that vision to try to be a partner in that vision of offering jobs while beautifying our community.
Well, that's right. I mean, there's going to be an acute shortage in healthcare workers between radiology techs, lab workers and clinical lab workers. And you go down the list, respiratory therapists. I mean, so this is a great pool of potential workers right here. And I think if we work with the city and the county to create educational opportunities, I think we can make a huge difference.
We have a question from Greg Gosick in the chat about how many times people are going to multiple practitioners, and especially for some of the older individuals, they may not even have the ability to connect the dots. And sometimes the practitioners are also not connecting the dots. Are there things that you're doing as a system to try to address this experience of having these separate meetings, even though the need from a care perspective is for these practitioners to be knowing about what each other is finding and doing, if that makes sense?
Yeah, this is like one of the biggest, I think one of the biggest dissatisfiers for patients is my specialists don't talk to each other. And, I'll never forget, I had a very good friend who was a rheumatologist at UCSD, and they were talking about people with rheumatoid arthritis that the rheumatologist would be the person that would sort of coordinate all the care. And his response to me was, this is my worst nightmare because I don't know anything about diabetes. And I realized that, primary care plays a role in this. There's going to be more and more complex primary care. And we're even talking about potentially having primary care doctors who are very focused on people who've had cancer. So after they've seen the oncologist, because they'll know the challenges that people who've had cancer will face, and they can be a more effective primary care doctor. We are not there yet. We're not there yet. And but I think the good news is there's a lot of thinking about it, about who can really be, use a football metaphor, the quarterback for someone's care. Because I think
Yeah.
that is really going to be important, because people get seven, like if you, like as you get older, you can have four or five specialists that you're seeing. You can see a cardiologist, you can see an endocrinologist, rheumatologist, and just fill in the gaps. And I think if they're not all talking to each other, and who's going to coordinate the medications? Who's going to
Yeah.
coordinate, like who do I see when? And if I start having a problem, who's going to help me sort of, sort that out? And what problem is it really? And I think this is going to be one, it's very expensive for the system in general, but I think it's really inconvenient for the patients. It can be sometimes a little bit dangerous. So I think what you're going to wind up seeing is a more data reinforced primary care situation. You
Yeah.
know, so I want to dovetail a situation that happened with my wife, because it was a really interesting one. So different place, different town. She broke a bone in one foot, and then after that healed, within a month, she broke a bone in the other foot. And so she went to an academic medical center, orthopedics department, and they said, we're not really sure what's causing this. It could be osteoporosis, but we're not sure. And then referred her to another academic medical center, which had a very good osteoporosis department or division. And they looked at it and they figured, we can't figure this out either. And then referred her over to a primary care doctor who was actually in private practice, and said, well, we're going to send you over there, because they really he's really good at diagnosing really complex things. So of course, runs a bunch of blood tests, totally diagnoses it. Turns out she had a wheat allergy. She was celiac, life changing. And,
Yeah.
and you think about the fact of her trek to get to that diagnosis, and the fact that three different physicians, they're all just sort of, and I thought, this is a sort of, we got to kind of concentrate these resources. So a patient can go one time, one place, that can get sort of figured out, and they can get sort of that well, for her, it was a complete life-changing diagnosis, because it's really improved her health, in a lot of different ways. But I also think it's very interesting how a broken bone was actually was really being driven by an inflammatory reaction to wheat,
Yeah.
and the complexities around some of these things.
I mean, Tom, where do you think we are in timeline from having AI be a key kind of underpinning of surfacing some of these possibilities? Because it strikes me on the question of how do we connect people's care across multiple providers, the question of how do you find sometimes these unexpected journeys to a diagnosis, that pattern recognition is one of the key vehicles. To your point about data.
Right.
And that's actually one of the things that artificial intelligence is quite good at, arguably better than humans, just because of its storage capacity and its ability to see things without the same types of bias. Even though it may replicate bias, right? It will be different in the nature. And so I'm just curious, as a health system, is that a conversation even happening right now? Is that far off? Where do you see that as a possibility?
No. Oh yeah. Oh no. It's a real conversation. It's happening now, and there are companies that are working right in this space. So for things like radiology, some of the technology already exists, right? And it's being incorporated in a lot of the systems about helping to sort of triage certain images, and so that it can really help focus the radiologist. I think in terms of what you're talking about, we're probably, I'll be optimistic, probably 3 years away, somewhere in the 3 to 5. There are companies that are really working on this. I have seen some really impressive demonstrations around this, and I think it's going to happen really quickly. And I think the timing is right from a health system perspective, because number one, I think there's a real patient demand. We're all facing a national shortage of doctors,
Right.
and that's not going to go away anytime soon. I've always say, the population of the U.S. in the year 2000 was about 280 million. It's about 340 million today. We haven't really increased the number of doctors anywhere near that, and we've had a lot of doctor retirements. Technology is going to have to help fill that gap. But I think it not only can fill the gap, but actually might even improve things, because it might connect more dots and really help physicians be more effective in their time that they're spending with patients. That's why I feel like I have one of the greatest jobs, because I feel like we're at the point of this real inflection point
Yeah.
We're going to see real changes in healthcare, both for all of us as well as people on the south side of Chicago. I see this helping, sort of, if you will, helping with a lot of the disparities and really improving care.
I want to get to more questions in the chat, but I want to lay one other topic on the table, and it's related because AI is driving some of the development. Biotechnology is having a moment. We're seeing really significant discoveries for human health. Can you just talk about what you see over the next decade, how those become accessible, and how you think those could shape, especially health span? I mean, most of what I've read is that, people are not necessarily living over 100 in much greater degrees than they are today, but people are living till 100 differently, potentially, as we look to the future with this biotechnological revolution.
Well, so this is exactly right. No, and I think that, it's interesting. The stuff that I've been reading, Seth, you're probably reading the same stuff, is where body is not really engineered to live like 200 years, right? We're going to start to sort of break down. But if we get 100 years, how do those 100 years be absolutely fantastic? And if you think about the stuff that's already happened, like hypertensives have done a huge job in sort of like, preventing heart attacks, statins in terms of cholesterol, same stuff. I think GLP-1s are going to become like statins. I think they're going to become part of everybody's regular regimen, about not because of the anti-inflammatory factors. And there's like a lot of sort of corollary benefits that are being discovered. I think the fact that as people talk more, as cancer gets more personalized and our treatments get more effective, cancer is going to be more like a chronic disease. And I think people will live and live better and live longer, and things that were fatal in the past won't be fatal anymore and won't do this. It's going to put challenges on a health system because we're going to be seeing more complicated patients for longer in their lives. But that's why we've got to change this. I mean, from a personal, as an individual, I feel like this is fantastic, right? There are going to be a lot of cures, and hopefully, at some point we'll have some kind of cure for Alzheimer's and dementia, so that'll be preventable as well. And so I think we're there. We're there today in a lot of this technology. I know the microbiome research. If you ask me one thing that is really fascinating, it's going to make a huge difference in our quality, is, remember that the old sort of cliche, you are what you eat. It turns out that really is true.
Yeah.
And I think we're going to get more focused on it. I think people are going to eat healthier, less processed foods. Um, Personally, I enjoy a good cocktail, but obviously you can't have too many because it's going to really mess up your microbiome. But I do think as we understand more of this, and I think University of Chicago is at the leading edge of the microbiome. We've got a great center here. We're doing a lot of work on this. And I think between having your own personal genetics plus your microbiome, I'd gotten some statistics today between the number of like cells in the human body, but then all the other sort of bacteria and stuff there are more bacteria, I guess, living in our body than there are cells in our body or whatever. And we've been very focused on our own sort of cellular makeup. Now we're flipping to looking at uh, all the other sort of, if you will, important biological factors that live with us.
So we have a question actually related to the what you eat is what your health becomes. Stephen Masnick asks, what role can a large health system like UC play in encouraging healthcare to focus on prevention and longer term health rather than acute interventions?
Yeah, that's a really good question. And one of the things that I think I probably, we, especially at the University of Chicago, we have built ourselves on taking care of the sickest of the sick. It's really where our strengths are. And at the end of the day, we're going to always do that. The real thing is about expanding primary care, expanding some of these general specialists. I think also making sure that primary care doctors have a lot more information to really focus on wellness. You know, that physician that I mentioned about that my wife went to see is an integrative physician. He focuses very much on looking over your diet, all your old blood work, if you will. So your vitamin levels, what you eat, and trying to sort of maximize, if you will, performance and health for you during, and honestly, my wife sort of got me to start to go to him, and I was actually really impressed because I think overall it has had a huge impact because I do watch it. I watch what my mercury levels are. And as part of this, so I sort of manage my fish intake. I look at this. If I need, obviously always everybody needs more vegetables, but but in terms of managing my overall, metabolism, I think it's really important. And I feel like to a certain extent, I I feel as I'm over 60 and I feel like I'm still about 50. So I hope this continues.
So we have a question here from Rosemary Mitchell about how health can be personalized when access, appointments, and number of doctors are limited. And so I'll share that one. We also have a question that I got privately about how the university is thinking about the future workforce of healthcare. And so I'll kind of combine those because we have a goal of personalization, we have a shortage of healthcare workers. How are you thinking about that? AI is potentially a disruptor in that equation, but an uncertain outcome. Yeah, just a little bit about how you're thinking about that duality of challenge.
So, so whenever I get together with sort of my peers, number one issue is always workforce. Are we going to have enough people, enough nurses and everybody else? And everybody's thinking about how we're going to train people. People are all trying to develop their own pipelines about beginning to train folks yourself so that you're going to have those future workers. I think that's number one. I don't think that's going to be the solution. That's going to be a stopgap because I do think the supply and demand are going to continue to separate. I think technology has got to play a piece in this. I don't. I think if we, what I always I refer to us as an FTE business, which is a full-time equivalent. We've always looked at people as the stopgap for every need that we've got, and so we've always continued to hire. All of a sudden now it's going to get a lot tighter to hire. And what are we going to do? And I think we're going to have to think differently. For folks who have been in healthcare, electronic medical records was really started about 20 years ago. And for the most part, I think they basically wore out nurses and doctors for 20 years because I feel like people felt like spending way too much time with a computer. And what I'm now seeing is technology. Like we just recently put in this a bridge, which is a ambient listening device that can actually populate the doctor's notes. We did a 200 doctor sort of sample, if you will. And what happened was the doctor satisfaction went up and the patient satisfaction went up because the doctor could talk to the patient and not worry about looking at a computer because it was capturing all the notes, and it really improved sort of the quality of the visit. And it made the doctor more efficient so the doctor could see more patients. It's one small example, I think, of where technology can really start to make a difference. And I think that's going to continue. I do worry about this. I worry about this from in my current role, but also as a patient, right? How am I going to make sure there's going to be access? There's been a lot of growth in concierge medicine, which at one level makes me very nervous because it does take access out, right? It improves the quality of life for physicians. They like it better. They get closer to their patients. But for a primary care doctor who'll have 1,800 patients in a panel, a lot of concierge doctors have 250 to 500.
Yeah.
It's sort of, so there are things along those lines I think are going to be challenges going forward. I think, I think there are going to be some increases in training programs, but overall, I think technology is going to have to play a key role in this.
We're obviously incredibly proud of what's happening at U Chicago Medicine, but there's a question in the chat. Are there other countries or maybe health systems that can serve as models for what we're trying to accomplish? Are there some peers that you look at, or maybe even other examples from abroad that are role models aspirationally for us?
Okay, so now we've got questions like what do I pay? Because I've actually joined some international groups just because I believe that there's a lot of opportunities. I also my wife is British and trained is a physician and trained in the NHS, and she's actually done some consulting around the world. So I get a big dose of this as well about what works in other countries, very anecdotally. But so I'm always very interested because I feel like every health system is kind of built around its reimbursement structure. And
Right.
what I mean by that is in the US, length of stay was sort of a financial incentive. So US is really good at having a low length of stay, right? Other countries have different financial incentives, got very good at other stuff. And the question is, what are really the best models and what can we, adopt in the US? So the short answer is absolutely. There's a lot of really good stuff going on around the world. And I'm a firm believer, if there's a good thing going on somewhere else, we should copy it and bring it in because there's there's a lot of people really thinking through these problems in every country. And while the US is really very good, there are very, very good ideas other places as well.
We have a question, Tom, about community relations, and point in the chat that there's a poor history of those relations, and citing a book by Thomas Fisher. Curious if you could just talk about where we are today and thinking about community relations. I know I've visited the trauma center, been in awe of what you're providing there, but you can talk more broadly about the university's approach.
Yeah, I think historically the University of Chicago has had somewhat of a complicated relationship with the community. And I think even not, closing the trauma center in the 1980s and reopening it in 2016, but not after a lot of the community really pushing. I think I'll give a lot of credit to this to Brenda Battle, who has sort of led our community initiatives for a decade. The relationships are much better, and I think with the Cancer Center and really trying to focus on Southside Cancer Center cancer issues has made a real difference. For me, this is it's one of the reasons why I took this job is really try to make a difference on the South Side. So we've got our community groups. We try to listen very closely to what some of the challenges are and try to fill those needs. But it's one where you have to continue to listen all the time, and you got to work on it all the time because the needs in the community are changing and so we've got to make sure that we're addressing those. I feel like if there's a silver lining in the pandemic, academic medical centers in general got more focused on their local communities. And I think here at University of Chicago, that would be us as well. And so I think it's one where you got to continue to work on it. I feel like the relationships are getting better, and I think we're going to have to get in even deeper in the community to really help with the health challenges because it's not. I just don't think we can make the difference that we need to make just by being in Hyde Park.
We have a question about how care is changing, very much building on what you described as the structure really being framed around the reimbursement system. It's from Annie. It says, has the Affordable Care Act and its revamping of some cost reimbursements such as ACOs and lump payments assisted with the quality and access in Chicago systems? Any comments on how that's influenced the care system?
Yeah, and really, it's just sort of okay, you got one person's opinion here. I think it's given more people insurance, which I think is a really good thing. I think some of the challenges around it hasn't really fixed some of the access problems because we didn't necessarily add doctors in those places, but we gave people insurance. So they gave them more flexibility, but nothing as close to home as what they would really want in really the easily accessible care. And that, sort of as I said, it's one thing to get insurance, but it's another one if you can't change the pattern of care around and people still use the ED for a good chunk of their care. Um, I think it's one, Medicare Advantage is having a bigger and bigger impact. I think Medicare Advantage is something we're seeing more on the south side of Chicago. I think it's one where, as I've said, is University of Chicago is going to have to, right now, for the most part, we treat it like it's Medicare fee for service. But I think going more, working closer with primary care doctors with the idea of trying to provide better, if you will, primary care so people don't have to come to the hospital. I mean, that's really, nobody wants to go to the hospital, right? At the end of the day, it's a very, it's one of those, I had an experience when I was out west about working very closely with a clinic in a major city. And it was really for some of the union workers, a beautiful clinic. You could go there completely for free, get your prescriptions for free. They asked us to co-brand it because people weren't really using it. They were still using the ED. Now, these were people that were employed in hotels and stuff. So they had a good insurance, but they were still using the ED. And what we realized is the fact, and they had to pay like $100 copay to go to the ED, but if they went to the clinic, it'd be free. But the thing was, people were working shift work, and the thing about it is that they could go to the ED and they can get their imaging, they could see a specialist, a primary care, they get it all done. And if you have a family, you could get, you can take you and your child there and you get it all done. So the value of the time, especially when people
Yeah.
were getting paid hourly, was so valuable that the ED was still more cost effective to use. And so what we learned about that is you got to have more flexible hours, especially when people are working on hourly jobs. It's like, if you're working a white collar job, you can leave for a couple hours from work. But if you're working an hourly job, you can't. And So I think these are the kind of things that are going to really, I think, make a difference in people's lives, and is open up the hours and trying to make healthcare more of a service business. I always tell my team is like, we are the most non-service service business ever.
Well, so we've talked a lot about systems. I want to close by talking about individual advice that you have,
Okay.
because you are at the highest level in healthcare systems. You are also personally very committed to your own wellness and development. Can you talk a little bit about, and I got a lot of great tips from you, I want our audience to as well. How do you approach the goal of health span and longevity? And what are some of the tips you have for people that go beyond the healthcare system in terms of that social determinants, and some of those that especially people that may have some privileges can decide on because of the luxury they may have of having discretionary choices around their health?
Yeah, so it's a couple things I think. So number one, like I exercise every day, right? I get up early in the morning. I go to the gym. I feel like it's a very good stress release, and it's a good way to get the day started. So I religiously exercise is part of it. Number two, you know, okay, this job is stressful, right? And there's no way getting around that. And but part of it is I've learned how to, like, if I go home, I'm gonna get off, like, I'm gonna get off the phone, right? I'm not gonna scroll. I'm gonna read, spend some time, talk to the wife, talk to the kids, and do that kind of stuff, because I do think you've got you've got to get a little bit of a mental break. Number three, a long time ago, people talk about work-life balance, and I realized I can't do that. This job doesn't really allow that.
Right.
And so I'm not going to stress myself out. I'm going to spend time with my family, and I'm gonna do the work thing. And so in some ways, in a very pure way, I've kind of simplified my life and tried to do that. But I will tell you though, in terms of, really, using integrative medicine and doing other things, about really trying to manage my overall sort of well-being and never taking it for granted. And, so making sure my, my, my vitamin D levels are good, zinc levels, all that kind of stuff. Actually, it turns out it really does matter.
Yeah.
And I think having that relationship with your physician is really important. So you can have those kind of conversations. And then if I do have a problem of some sort, I never let it linger. I deal with it. I deal with it right away. It's like, and it's not like, because I realize it's like, okay, I got one body, and I'm going to do whatever I can to keep this thing going. So I don't usually ever let anything slide. So if it's like, okay, if if I hurt my knee, I'm gonna go get it checked out. I'm not gonna like limp around for like 3 weeks.
Well, and one thing I love that you said that I think is just a great way to think about, and this is for the leadership side of what we do, is that if you're in leadership and a lot of people are depending on you, you almost need to treat your wellness a little bit like an Olympic athlete. Obviously, probably not quite to that level, but the idea that, your ability to positively impact other people, your ability to show up with care and wisdom and energy, that really depends on your wellness. And so it might be very easy for someone who has a lot on their plate to say, oh, I'm going to cut that doctor's visit, or I'm going to cut that workout, because you're like, I'm going to get this much more time. But then when you think about it as an athlete, you say, oh, yeah, but I'm not going to be as effective in the time that I have. So it may actually not be the right equation, that cutting out all of my personal wellness just to do more work actually leads to a better outcome. And anyway, for me, that was a really interesting
Well,
framework to think about it.
well, I'm glad you brought this up, because it's exactly how I think about it. And I actually tell this to my team. I said, you have got to think of yourself as a professional athlete,
Yeah.
because your body is exactly the same. If your body fails you, you cannot do this job, right? And then I'll use the example of, like, take a really great player. You can be the greatest player, but if you get hurt all the time, the team's going to cut you because you're never on the field. You got to be on the field every day. So you got to take care of your body, because your body will wear out. And it's very interesting in, being older. And I have to say, I really got started on this probably in my late 40s, where I thought, if I'm going to do this, I better really take care of myself. And so I will lecture, I will lecture my team over this and say, you gotta take care of your body. Think about it like a professional athlete would. And it's interesting, some of our senior faculty, some of the surgeons think about it exactly the same way, because medicine, like to be a surgeon, it is a very physical job. You're bent over for hours at a time. You're on your feet. If you don't take care of your body, it's going to fail you and you're not going to be able to do your job. And I think that's the moment of, and actually, and to a certain extent, the fact that these jobs are sedentary are probably a bigger stress than if you have a more, so you almost have to almost compensate for the fact that we sit too much in our jobs.
Well, I would continue this conversation, Tom, but we're at time and I need to go take a run because I've been sitting for the last 40 minutes.
You and me both, we both should do
I'm a
that.
professional athlete here. I've got to get going. Truly, this has been a spectacular conversation. Most of all, thank you for the role you play. I think the fact, and I know it because I know you, that you took this job because you were thinking about how you could improve the care in our community is such a testament to the expertise and compassion that you bring. We really appreciate it, and we're grateful for your insights on longevity, both at a system level and then at a personal level. I look forward to integrating a lot of your lessons. I'm in my mid-40s, so I'm going to get a little start on your late.
Oh yeah, you're in good shape.
Thank you so much, Tom, and thank you all for being with us.
Thank you very much. Bye.
Bye.